اوكي بسم الله. So أحل هذا السؤال. I will start counting the time to solve this question, then I'll explain why I choose and how was the process of solving the question. So Bismillah. Okay. So I'm not sure about this question, but let's see. Oh, Bismillah, Alhamdulillah, MashaAllah, MashaAllah, لا قوة إلا بالله. Okay, so migraine therapy. I'll read the explanation. How I solve the question. Uh, I'll explain it, and yeah, first I read the last. I read the last sentence of the question. So, which of the following is most appropriate? Preventive therapy. Preventive therapy. It's equal like the prophylaxis. Prophylaxis. So I think about the preventive, how to prevent these episodes of what. Uh, uh, I go back to the first line, and she is a 31-year-old woman, 12 weeks. She meaning she is in the first trimester. Recurrent headache. She has a recurrent headache. Come to the office, not emergency. She has a history of episodic migraine that typically resolve with NSAID, but become when she is becoming but since becoming pregnant, the headache had become more severe and frequent over the past month, meaning the first time so also, but the 8 weeks. Patient has had 5 migraine headaches and associated nausea, vomiting, required treatment, emergency department. So she entered the emergency department from the headache, because of the headache. So the temperature is normal, blood pressure is normal, pulse is normal, you can say, and fetal heart rate is upper normal, 110 to 160. So yeah, cranial nerve intact, deep DT reflex, deep tendon reflex is 2 plus, meaning normal response, and sting sensation are all normal in all extremities. So I know that the prophylaxis for migraine is by beta blocker, and the treatment is by sumatriptan, most effective. So that's my knowledge. So I solved the question on this knowledge, and I'll read the explanation and see what I'm missing. So okay, migraine therapy, triptan, and said okay, triptan is the first, and said acetaminophen. This is abortive. Okay, treatment, and said acetaminophen, antiemetic, ergo ergotamine, preventive and anticonvulsant, topiramate, valproate, beta blockers, and antidepressant, tricyclic, and venlafaxine. Venlafaxine. Okay, migraine headaches, frequent migraine with significant impairment, preventive therapy during the pregnancy, beta blockers, propranolol. So the most answer choice C, then E, then F. So let's see. Migraine headache, how common in women? I'll read the explanation and say if there anything I want to say. Mm-hmm. Beta blocker have the best fetal safety profile, so they are the first line prevention during pregnancy. Okay, initiated in the lowest effective dose and acquire frequent monitoring because it has a potential to cause growth restriction, decrease placental perfusion from low blood pressure. So we say the E, ergotamine, and triptan, somatriptan, uh, ergotamine and somatriptan E. So can be used as a bolt. Yep, as a bolt, an acute used to abort an acute migraine, but are not typically used for migraine prevention. In addition, these medications are not used in pregnancy to the risk of fetal anomalies, ergotamine, growth restriction, triptan. Fetal anomalies of ergotamine and growth restriction, triptan, and preterm labor of both. Okay. Uh, we have the sertraline. Okay, topiramate. Topiramate is effective for migraine prevention, but avoiding pregnancy due to risk of fetal abnormalities, cleft palate, low birth weight. So sertraline uh, is safe for use in pregnancy to treat depression, anxiety, and like tricyclic antidepressant, venlafaxine, and the venlafaxine, which are used for migraine prevention. In non-pregnant patients, sertraline does not prevent migraine. Doxylamine. So wait a minute. Okay, doxylamine, first generation antihistamine, often in combination with pyridoxine, is used to preventive antiemetic. For example, hyperemesis in pregnancy. It is not used for migraine prophylaxis. Okay, that's it. And yep, it's 5 minutes. Let's go to the next question. And see how I will Bismillah. Okay, so this question is I don't know what to say صراحة. I'm not sure, but I choose this answer choice, and Bismillah. Oh, Alhamdulillah, mashallah. So mashallah, it's most likely the answer, and why I choose it, how I I reach يعني the answer, correct answer. Bismillah, let's explain. So the first, I read the last sentence and the most helpful in establishing this patient diagnosis. There's a diagnosis and how to diagnose. What is help us to diagnose the that case or this case, and the answer choice CT, echo, pulmonary function test, quantitative p-test, beta HCG test, and ventilation perfusion scan. The context, so I follow the context, chronology, severity, framework. It's framework طريقة تعتمد على الكونتكست، سياق، الكرونولوجي، ترتيب الأحداث، and severity، شدة الحالة. So the 29, I go back to the to be honest, I read the last. I go just one sentence back, and its complete blood count and serum electrolyte are normal within normal limits. So okay, that the CBC and the electrolytes normal. Okay, so yeah, chest X-ray reveal multiple bilateral infiltrates of various shape. Okay, so this me- m- means something. Okay, so what is multiple bilateral infiltrates of various shape? If I go and see the context, I will understand this sentence. Okay, this hint. So I go back. I went back to the first sentence, and it's 29 emergency department with chest pain dyspnea for 10 days. Chest pains bilateral, dull, persistent, non worse with activity or exertion. The patient's medical history is significant. That's it. This is the hint. This is the leading point. So, the significant medical history for normal spontaneous vaginal delivery 3 months ago, after which he had frequent episodes of dark blood vaginal discharge. Okay, the most recent bleeding episode was 6 days ago. So, postpartum bleeding. Postpartum bleeding. It's we know that atony, tone, tissue, and trauma and thrombin. And to be honest, one of my friend uh, tell me told me yesterday a thing that helped me solve this question. He just give me like, what's the cause of postpartum hemorrhage after like weeks, and I said, oh, I said thrombin. He said, no man, it's like it's the tissue. It's the tissue, a retained placenta. So a retained placenta after the vaginal delivery, and there is multiple bilateral infiltrates of various shape and chest X-ray. Okay, so what could be that cause and affect the lung after vaginal delivery? And both there's bloody vaginal discharge, episodes, chest pain, dyspnea. Uh, I I instantly get uh, the alarm of choriocarcinoma. There's tissue, retained tissue after after pregnancy, and go to the lung. So, yep, that's the answer. So, how to diagnose it? What help us? The quantitative beta ICG, because it will increase. So, choriocarcinoma. Uh, let's choriocarcinoma is choriocarcinoma risk factors for this one. Or let's see this the explanation is a form of gestational trophoblastic neoplasia. It's neoplasia, gestational trophoblastic neoplasia, a malignancy that arises from placental trophoblastic tissue and secrete beta ICG. Although it most commonly follows a hydatid mole, choriocarcinoma can occur after normal gestation or spontaneous abortion. That's it. That's it. You should know that. Okay, you should know that choriocarcinoma can follow not just a hydatid mole, ليس فقط الحمل العنقودي, but can occur after normal gestation, حمل طبيعي, and spontaneous abortion, الإجهاض or إسقاط. So the choriocarcinoma typically present less than 6 months after pregnancy. Patient symptoms include irregular vaginal bleeding, enlarged uterus, and pelvic pain. So yep, there is enlarged uterus here. Here they say enlarged uterus, and okay, enlarged uterus and pelvic pain. Critical aggressive type of gestational trophoblastic neoplasia. The most common site of metastatic spread is to the lungs. Symptoms of pulmonary metastasis include chest pain, hemoptysis, dyspnea. When carcinoma is suspected, obtaining quantitative beta-ICG level helps to confirm the diagnosis. So, I said it's postpartum hemorrhage, but it's not a postpartum hemorrhage. It's a choriocarcinoma. It's a choriocarcinoma, but the so I explained it wrong, to be honest. Like postpartum hemorrhage and it's tissue. No, not like that. But it's like gestational trophoblastic neoplasia is an entity itself. So advanced risk factor for choriocarcinoma is prior complete hydatiform mole or any normal gestation or spontaneous abortion and advanced maternal age. So she's 29, not advanced. So presentation amenorrhea or abnormal uterine bleeding, yeah, or amenorrhea. So she is presented with abnormal uterine bleeding, pelvic pain, pressure, symptoms from metastasis, lungs, vagina, uterine mass, and elevated beta ICG, which is the answer. Chemotherapy is as treatment. So the answer choice, they 16% choose CT scan. CT of the chest. A ventilation perfusion scan is best at identifying pulmonary embolism. Echocardiogram show evidence of myocardial infarction and heart failure. A pulmonary infarction test can identify obstructive and obstructive lung disease, although pulmonary embolism, myocardial infarction, obstetric, restrictive lung diseases could all explain this patient's dyspnea and chest pain. None of them explain her irregular vaginal bleeding. Furthermore, her chest X-ray findings are most consistent with metastasis. The answer of CT, a staging system for choriocarcinoma, relies on chest X-ray rather than CT finding. Therefore, in this patient with known pulmonary metastasis on chest X-ray, CT is not indicated and would not change management, even among patients with carcinoma who have a negative chest X-ray. The detection of metastasis on chest CT scan is not associated with a worsened outcome, even among patients with carcinoma who have negative chest X-ray. Detection of metastasis on CT scan is not associated with worsened outcomes and does not alter management. Okay, so we depend on the X-ray, and that's it. So if I recap, it's just choriocarcinoma. You just should know that choriocarcinoma can present after less than after delivery, normal gestation, and after abortion, and most likely after complete hydatiform mole, but also a normal gestation, after normal gestation. So the time is less than 6 months after pregnancy, and she is like pregnancy normal vaginal delivery 3 months ago, so it's less than 6. And yeah, that's all the question. I'll do the same. Bismillah. Okay, I'm not sure, and but just I should did it. يعني I should do it. And Bismillah, let's say. Oh, yep, bladder dye test. Bladder dye test. Why? Let's see. So, oh man, oh man, oh man, that's that's so amazing. I need this question. I need it. So this patient, let's start. So the how I solve this question wrong, I get it wrong, is by let's explain. I read the first sentence and it's like establish what would most likely, which of the following would most likely establish diagnosis in this patient. So let's I just give a glance, fast rapid glance of the answer choices, and a bladder dye test. Actually, I don't know what is that, so I just cross it, but it's the correct answer. Cervical nucleic acid amplification test. I suspect this because she is 19, and wet mount microscopy, E, and urinalysis, urine culture, viral culture of the lesion. So I was like between these two. Why? Because she's 19 and the continuous vaginal discharge. Uh, I read the last thing. The cervix has no lesion. There's pool of clear fluid in the vagina with pH is 6. Definitely, I wasn't thinking about the cystovaginal fistula. So, yep. And this is a urine pH, alkaline pH of 6. So, pelvic exam show hair well healed, third degree perineal laceration on speculum. There's small red area of granulation tissue on the anterior vaginal wall. So this is uterus, this is the vagina, and this is the bladder. And this is the bladder, this is the uterus. Oh, the first one was like perfect. This is the uterus, and this is the bladder, and yep, rectovaginal fistula between the bladder and the vagina. Why? Okay, let's see. Clear, slight mother's vaginal discharge from past week, but no pelvic pain, dysuria, vulvovaginal. There's no pelvic pain, dysuria, vulvovaginal pruritus. 6 weeks postpartum from vaginal delivery on stillborn male infant after 3 days of labor. Okay, and 4 hours of pushing. So this is a prolonged labor, prolonged first stage. She has no prenatal care, delivered at home. Okay, so why it's wrong, why the correct answer is the answer, and let's see. The patient has a I said sister, it's a vesicovaginal fistula, a complication of obstructed labor that is common in all resource limited areas, sub-Saharan Africa, due to young maternal age, small pelvis. Okay, so Complication of obstructed labor is vesicovaginal fistula, result limited area. So at young maternal age, small pelvis, and limited or no prenatal care, which result in delayed diagnosis and labor intervention. Obstructed labor is the most common cause of vesicovaginal fistula worldwide, with an estimated more than 100,000 new cases yearly. In this patient, vesicovaginal fistula develops because excessive fetal head compression during obstructed labor causes injury and necrosis to the maternal vagina, rectum, bladder. Two, tissue necrosis leads so the excessive fetal head compression because the pelvis is small pelvis, young maternal age, and no prenatal care, limited. There's obstructed labor. Obstructed labor cause excessive fetal head compression during obstructed labor cause injury, necrosis to the maternal vagina, rectum, bladder. The tissue necrosis lead to erosion and fistula development between proximal structures, vesicovaginal and rectovaginal, typically occurring within the first weeks postpartum. Leads to erosion, fistula development between proximal structure, vesicovaginal, and typically occurring within the first weeks postpartum. Because proximal structure, vesicovaginal, rectovaginal, which is typically occur because of the apparent connection between vagina bladder. Patient with the vesicovaginal fistula have a continuous vaginal discharge with an abnormal continuous vaginal discharge. That should ring the bell on my head, but it's continuous vaginal discharge. Yeah, because of apparent connection between the vagina and bladder. Continuous vaginal discharge with abnormal elevated pH due to urine, which may be moderate due to surrounding necrotic tissue. Pelvic examination typically show vaginal bulk of urine, a visible defect, or an area of raised red granulation tissue on the anterior vaginal wall. Bladder dye testing is performed to confirm the diagnosis, particularly bladder dye testing, particularly in patients who have small fistula that are not visualized on pelvic exam. During bladder dye test, the bladder is filled with a dyed fluid, and patients are monitored for vaginal leakage of dye due to speculum examination or tampon placements. Wait a minute. During bladder dye test, the bladder is filled with dye fluid. Patients are monitored for vaginal leakage of dye via speculum examination or tampon placement. Tampon placement. Treatment of vesicovaginal fistula is with surgical repair. So the bacterial vaginosis, my answer, can be diagnosed by using wet mount microscopy. It causes thin, malodorous, fishy odor discharge with an elevated pH. Bacterial vaginosis does not cause vaginal building or carnage tissue, making this diagnosis unlikely. And the cervical nucleic acid amplification testing for chlamydia, gonorrhea is indicated in acute cervicitis, which typically presents with cervical friability and mucopurulent cervical discharge, not seen in this patient. Urinalysis and urine culture are used to diagnose urinary tract infection, which is common postpartum. This patient has no dysuria or suprapubic pain. Therefore, so let's go to the next one, and this is a bladder dye test. This is the catheter, tampon. They use tampon, so catheter, syringe with dye. They inject the dye on the bladder. Then the tampon will the dye will travel through the fistula, and here the dye will be on the on tampon, blue dye. So yep, let's see the next one. Okay, Bismillah. Oh man, oh man. So I want to choose either this or this one, and let's see. Say the third option is, wait, she 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 her BMI is 28. Does that indicate something? Does that indicate something? No, no, no. So control hypothyroidism would be bilateral, and fat necrosis most likely. But she has dyed blood on the left nipple. Serosigenous discharge is expressed. Serosigenous discharge is expressed. So either Paget disease, Bagot disease, bag disease, or interdactyl papilloma. Interdactyl papilloma. And what will I choose? I'll choose between these two. And she is 45, nulli gravida, intermittent nipple discharge. So I go with D, although wait a minute, why I changed my fat necrosis? Oh, it is D. Oh man. Oh man. So, yep. Yep. Why? Why I choose it? So let's. Wow. 4 minutes for question. Which of the following is most like cause of this patient presentation? Patient presentation. She presents with nipple discharge intermittent. She's 45 and she's newly gravid. This is a risk factors. Okay. She has a something like she has a trauma. Did have a trauma to her breast and skying 3 months ago. but the for the past month she has the discharge on the left, and no breast mass, breast pain, but she did have review of system negative hypothyroidism. So this is also something. Take levothyroxine for her hypothyroidism. Family history unremarkable. She does not use tobacco, alcohol, also drugs. Blood pressure normal, pulse normal. BMI is slightly high. No bellable breast on pelvic physical examination shows no bellable breast masses, and there is dyed blood on the left nipple, serosvaginal discharge, express. So yeah, I said that this is between these two answer, and I ended up choosing the wrong one. There is no axillary lymphadenopathy. Mammography show no masses or calcification. So this should exclude the fat necrosis calcification, but maybe micro calcification, not visible. But let's see why it's not fat necrosis. So the fat necrosis. Okay, let's start time up. Fat necrosis of a breast is a benign condition caused by breast trauma. It typically presents a firm, palpable, irregularly shaped mass. Nipple discharge uncommon on fat necrosis. Okay. So the bag disease of breast is something I think about. I want to choose, to be honest. Bag disease of breast form of ductal carcinoma cause unilateral bloody nipple discharge due to intraductal tumor growth or necrosis. So the intraductal papilloma, not intraductal, the same thing. Intraductal tumor growth or necrosis. However, patients typically have eczematous nipple or skin change, flaking, casting. Okay. Why it's not the poorly controlled hypothyroidism? Stimulate hypothalamic release of the thyrotropin releasing hormone, hypothalamic release of thyrotropin releasing hormone. Yeah, because it will be low negative feedback, so increase the thyrotropin releasing hormone, which increase both TSH and prolactin release by the anterior pituitary, increase prolactin levels, can cause physiologic nipple discharge, galactorrhea, which is typically bilateral. Yep. Serosvaginous. And ductal ectasia, benign breast duct thickening and dilation. Ductal ectasia, benign breast duct thickening, dilation can lead to bloody nipple discharge as the duct widens. However, ductal thickening typically clog the duct, resulting in buildup of fluid, overlying skin erythema, and nipple pain, which are not seen. Okay. So تغلق clogs the duct, buildup of fluid, جمع الفلويد, erythema, nipple pain. Although intraductal papilloma can contain foci of ductal carcinoma in situ, 90% of patients with ductal carcinoma in situ have microcalcification on mammography. Patient is normal. A nipple discharge is is a common breast condition and calcified as either physiological criteria or pathological concerning for malignancy. Pathologic nipple discharge that is unilateral, bloody, so spontaneous. So these are all the criteria for this patient: unilateral, bloody, and spontaneous. Associated with other breast abnormality, breast palpable mass, or skin change. So these two I just فقط ركزت على هذه الاثنين abnormalities, and forget about the unilateral, bloody, spontaneous. And yep, the most common 50% cause of unilateral bloody nipple discharge without a coexistent breast mass or lymphadenopathy is intraductal papilloma. originate from breast. So time what I'm saying. Uh, Intraductal papilloma originate from the breast duct lining and are typically non-palpable due to their small size. Intraductal papilloma small size and intraductal location. So they are not palpable. Although this benign condition is the most likely, alhamdulillah, this benign condition is the most likely diagnosis. Bloody nipple discharge can also be a sign of underlying breast cancer, invasive ductal carcinoma, caused by tumor growth into the lactiferous duct system. Therefore, patients with pathologic nipple discharge require breast imaging, either ultrasound less than 30, age of 30, mammography plus ultrasound more than 30. With small ductal papillomas, mammography is often normal due to low sensitivity for ductal pathology. However, ultrasound may demonstrate a dilated duct due to the space occupying papilloma. So that's it for this question, and we solve the last one after 1 minute. So I get this question wrong, but the next one, which is this one, inshallah I get it right. Correct. So let's go to the okay, so this is the last one on this block, and Bismillah. So basically, I choose the answer, and yep. So this is the how to say it. Okay, let's see the answer. Bismillah and Alhamdulillah. So primary dysmenorrhea. Primary dysmenorrhea, endometriosis. There's a primary dysmenorrhea versus endometriosis. Endometriosis versus primary dysmenorrhea. As Mike said, Millman Medical, PDF, it's the pelvic exam. On examination, there is a negative examination. She is having pain, but on examination there is nothing. So this is primary dysmenorrhea. If there was pelvic examination was positive, then this is endometriosis. And let's see. Alhamdulillah. So this adolescent's regular painful menses after the establishment of ovulatory menstrual cycle is consistent with primary dysmenorrhea. Regular painful menses after the establishment of ovulatory menstrual cycle. During mens, the endometrium produces releases prostaglandins. The endometrium produces and releases prostaglandins, stimulating uterine contractions and promoting endometrial sloughing. Patients with primary dysmenorrhea have increased endometrial prostaglandin production, which causes uterine hypercontractility. So those with primary dysmenorrhea increase endometrial prostaglandin production, which causes uterine hypercontractility and hypertonicity and resultant ischemia. Therefore, lower abdominal pain which can radiate to the back and thighs is typical, usually beginning 1 to 2 weeks or 2 weeks prior to men's uterine contraction. So why? Because as uterine contraction initiate endometrial sloughing. This abdominal pain is typically usually beginning 1 to 2 days prior to mens. Why? As uterine contraction prostaglandin initiate endometrial sloughing, and resolve after days after the mens onset of mens as the endometrial lining thins, because endometrial lining is the manufacturer of the prostaglandin, which causes the pain. Why it causes the pain? Because causes uterine hypercontractility to hypertonicity. So all the thing of the primary dysmenorrhea is the endometrial lining make prostaglandins, and the prostaglandin cause a uterine hypercontractility and hypertonicity. These hypercontractility and hypertonicity cause ischemia. Therefore, will cause pain, lower abdominal pain. Usually begins 1 to 2 days prior to mens. Uterine contraction initiate endometrial sloughing. And resolves a few weeks. Endometrial line thins. Patients also often have associated malaise and dizziness and gastrointestinal symptoms. Pelvic examination is normal and can be deferred in patients who are not sexually active. First line treatment in non-sexually active patients, such as this one, with primary dysmenorrhea, is non-steroidal anti-inflammatory drug because they inhibit prostaglandin synthesis. In sexually active patients, combination oral contraceptives are an option because they suppress ovulation, provide contraception, as well as decreasing prostaglandin release. So they suppress ovulation, provide contraception, as well as decreasing prostaglandin release. So why it's not like the other answer choices, like D? Let's see D. D prostaglandin only pills, progestin only pills are not as effective as NSAID or combination oral contraceptive because they do not decrease endometrial prostaglandin synthesis. Why it's not F? Tranexamic acid is used in women who have heavy regular bleeding and for whom combination oral contraceptive are contraindicated. Thromboembolism. This patient has light bleeding. SSRI is the first line treatment in patients who have with premenstrual syndrome and premenstrual dysphoric disorder. Although this patient has associated malaise, she does not have enough 5 systemic symptoms to meet PMS or PMDD criteria. The copper containing intrauterine device is not used for treatment of primary. So we reached the 5 minute. Gonadotropin releasing hormone agonist leuprolide can be used in the treatment of endometriosis, as we said, endometriosis. Um, Leuprolide can be used in the treatment of endometriosis by suppressing ovulation. In contrast to this patient, those with endometriosis have pain throughout the menstrual cycle and often have chronic pelvic pain, and also have pain throughout the menstrual cycle, not just days before. And yep, that's it for this question. Alhamdulillah, we get this right. We get this wrong, and we get this also wrong, I think. Yeah, get this also wrong, and we get this alhamdulillah right, and we get this alhamdulillah right, and we get this right, and we get this right, alhamdulillah. And I get this question wrong okay, yesterday. Solve it. And yep, that's all of it. If I count this, there's 22 question, 1 2 wrong, and 3 wait a minute, 1 2 3 okay, okay, 4 4, this is 4, and yep, this is 5, this is 6, and yep, that's from 22 question, 6 is wrong. So the rest is 18, I think 18 or 16 is correct, and 6 is wrong. Alhamdulillah.